Andrew, the phrase I keep hearing is, a little alcohol is good for you. It shows up around red wine, dinner culture, and stress relief. Is that a real health recommendation, or mostly a leftover from observational studies and lifestyle branding?
I would call it risk exposure, not a nutrient. The flattering moderate story usually comes from comparing groups of people, not assigning alcohol like a medicine. People who drink lightly may also have better access to care, different diets, different social networks, or fewer illnesses that made them stop drinking. That does not prove the ethanol improved health. It only tells us the drinking category may be carrying other advantages. Mechanistically, alcohol is unusually direct. Ethanol is small, water-soluble, and absorbed quickly from the stomach and small intestine. It reaches the brain, liver, and circulation before it is fully processed. The liver converts it first to acetaldehyde and then acetate, but that first intermediate is reactive. So just a beverage still becomes a body-wide chemical exposure, not something the gut simply neutralizes.
So the relaxed feeling is real, but not automatically beneficial? If alcohol changes brain signaling in a moment, how should someone interpret that warm, calmer sensation after a drink without confusing it with actual recovery?
The calm is pharmacology, not resilience training. A 2026 systematic review in adolescents and emerging adults found acute stress was most consistently linked with increased alcohol craving, especially in heavier drinkers. Evidence on actual consumption was more mixed because lab stress, drinking history, and setting all matter. But the pattern matters. Stress can make alcohol more salient, and heavier use can alter stress reactivity. That is a loop, not a stable coping skill.
The benefit story usually centers on the heart, but cancer feels less negotiable. If the body has to metabolize ethanol through the liver, what does the supplied evidence say about alcohol and liver cancer specifically?
The liver cancer meta-analysis pooled 126 studies and more than 86 million participants. Viral hepatitis carried the largest liver cancer odds ratios, but alcohol use still showed a significant association, around or 2.4 in that analysis. That is not a reason to panic after one drink, and it is not the same magnitude as hepatitis B, C, or D. It is a reason not to market alcohol as liver neutral or as a wellness shortcut. Baseline context is the whole ladder here. Someone with hepatitis B or C, fatty liver disease, prior liver injury, or rising liver enzymes is not in the same category as a healthy low-risk adult at celebration. The same exposure can sit on top of different risk stacks, and those stacks decide how aggressive the no-use advice should be. Alcohol advice is therefore personalized by liver context before it is personalized by preference. For blood pressure, the packet gives us an indirect but useful clue. In a hypertension dietary intervention, CRP fell more clearly in people who did not consume alcohol. That does not prove alcohol caused inflammation in everyone, but it fits the practical pattern. If blood pressure is already a problem, alcohol is rarely the missing therapy. The higher yield move is diet quality, medication adherence when prescribed, monitoring, and reducing exposures that complicate control.
Where should the conversation stop being nuanced? Pregnancy is the obvious one because a fetus cannot choose the exposure and the risk tolerance is different. But are there other situations where the clean answer is simply no alcohol?
Yes, pregnancy is not a moderation puzzle. The Centering Pregnancy trial in the packet is not an alcohol dosing trial, but it shows something important. Structured care improved knowledge and several maternal outcomes, and healthy primigravida and multigravida participants were less likely to consume alcohol postpartum. Support systems can change behavior without pretending alcohol is therapeutic. That is the positive lesson. Build care, coping, and follow-up around people rather than debating a safe social dose during pregnancy.
People often judge alcohol by the first hour, not the next morning. If someone says, "I sleep faster after a drink," what should they actually measure so they are not rewarding sedation while missing the recovery cost?
Use a boring self-experiment. Pick 2 to 4 weeks with no alcohol and compare sleep continuity, resting blood pressure if you track it, training recovery, reflux, mood, and cravings. Keep the rest of life as steady as you realistically can. If those markers improve, that is more actionable than a population curve. If nothing changes, you still have not lost a nutrient, because alcohol is not required for physiology. But there is a major boundary. If someone drinks heavily, has morning drinking, shakes, withdrawal symptoms, blackouts, or repeated failed attempts to cut down, they should not treat this as a casual challenge. Withdrawal can be medically serious, and stopping abruptly may be unsafe for some people. That is a clinician conversation, not a willpower contest. Evidence-based therapy for alcohol use disorder exists, and needing it is a health signal, not a moral failure.
That treatment point is important. Is the best evidence here just try harder? Or do newer studies suggest specific skills can help people drink less by changing how they handle emotion, craving, and stress?
Specific skills do help some people. In a 194-person randomized trial, adding emotion regulation treatment to cognitive behavioral therapy improved percent days abstinent at follow-up compared with the active health and lifestyle control, though it did not solve every drinking outcome. Separately, remember the everyday safety collisions. Alcohol with driving, sedating medicines, medical procedures, or liver disease is not a small wellness trade-off. Those are situations where the practical instruction is avoidance, not optimization. So the compressed rule is alcohol may be part of some adult social lives, but it is not a health prescription. Do not start for cardioprotection, stress relief, or longevity. If you drink, treat it as optional exposure. Keep an honest eye on sleep, blood pressure, liver context, cancer risk, craving, and relationships, and move toward less whenever the body's audit says the cost is showing. The responsible middle ground is not panic. It is refusing to call a toxin a nutrient.